For the last speaker for this session, we'd like to invite Dr. Robert HYDE to share with us on gene therapy for ophthalmic diseases.
Good afternoon. Thank you for the invitation to speak today. Some of the excellent preceding talks I've made, I think a lot of my initial slides here in this talk a bit redundant, but I'm just going to review some of the recent advances in clinical trials for gene therapy in ophthalmic diseases. Just by way of disclosures, I am a consultant for Janssen, which is a sponsor of one of the trials whose published results I will discuss as my funding is as stated. So we've seen before that there are a number of different ways to approach gene therapy, and gene therapy can be done to either modify or manipulate the expression of a gene or to alter the biological properties of living cells for therapeutics. Depending on the type of genetic disorder and disease, any of a number of strategies could be used to have therapeutic effect, including a gene augmentation or replacement strategy, a gene editing strategy with CRISPR-Cas9 techniques, for example, gene silencing with RNA, or using a gene that can actually modify the expression of other genes. And so it's known as kind of a modifier gene therapy approach. So the following talk is not exactly comprehensive of all these different approaches, but just wanted to highlight some of the advances that may have some of the broadest implications or that are farthest along currently. So we've already reviewed some of the history of gene therapy by the preceding excellent talk, and it's amazing to see where we are after maybe 30 years of research from first being able to identify viral vectors for gene delivery to the development of a therapeutic with Luxturna, which, as we know, has been used to treat LCA due to biallelic mutations in 2017. And so there's been well over 1,000 active clinical trials using gene therapy, and we have potential treatments for the previously untreatable. Luxturna, as mentioned, was approved in 2017 and is the concept here is subretinal gene delivery of RPE65 using an adeno-associated virus. And it's really been a benchmark for how future trials have been developed, primarily because of its success. It's shown durable improvement on, for several years after the initial trials. The outcome in the initial trial was a multi-luminance mobility test, which was something that had to be really developed for a specific function that was being assayed here, which was improvement in rod photoreceptor function. And remarkably, many of these patients showed improvements immediately after treatment, and those were sustained after 4 years. And other improvements were also noted in perimetry and full field light sensitivity thresholds. So the majority of the trials in ophthalmology have focused really on a gene augmentation strategy. And as you can see here, there's been, of all the trials, many of them have been focused on that strategy, but others have also been used for other types of diseases, including not only retinitis pigmentosa and Leber congenital amaurosis, which are primarily diseases that affect rod and RPE cell function, but other types of diseases included Leber hereditary optic neuropathy, choroideremia, X-linked retinoschisis, and so on. But to date, we still only have one FDA-approved gene therapy for an inherited retinal disease. Gene therapy for X-linked retinitis pigmentosa due to variants in RPGR, probably among all inherited retinal diseases, has shown probably the most significant and meaningful effects in several large clinical trials. RPGR accounts for 70% of X-linked retinitis pigmentosa, or about 1 in 40,000 males. It usually is more severe than other forms of RP, with children affected usually with the first decade of life. And phase 1-2 studies sponsored by Nightstar and Mira GTX for subretinal delivery of RPGR were promising, and these companies were then acquired by Biogen and Janssen, respectively. Beacon Therapeutics has another trial, and 4D Molecular Therapeutics had one that was recently discontinued. So I just wanted to briefly highlight the results of the gene therapy trial that was conducted by Nightstar, now Biogen. This was a phase 2-3 study of patients aged 10 years of age or greater who were treated with subretinal gene delivery using the AAV8 vector. There were about 29 total participants. And the primary outcome was microperimetry median responder criteria, which meant more than a 7 decibel gain at 5 of 16 central loci. You can see the kind of represented images of the microperimetry data in the untreated and treated eye, and you can see that that was quite a significant change, but unfortunately the study did not meet its primary outcome. Secondary outcomes were also encouraging, though, and some patients showed durable gains in retinal sensitivity far after treatment, so somewhat reminiscent of the Luxturna experience. Janssen is now conducting a phase 3 study of subretinal delivery of RPGR using AAV5 in 97 patients with X-linked RP. The primary outcome is change in performance on a vision-guided mobility assessment akin to the maze used in the Luxturna trials. There are many secondary outcomes, including retinal sensitivity and questionnaires, as is the usual case, but there's reason to be optimistic about both sets of outcomes based on their earlier trial results. And in the earlier phase 1-2 trial, there were significant improvements in the primary outcome, which is a maze, at 26 weeks following treatment. And as you can see in the chart on the left, treated patients took far less time on average, about 37 seconds. Sorry, the pointer's not cooperating. In the maze that mimicked deep twilight, so the darkest conditions that these patients were asked to perform. And there were also significant improvements in secondary outcomes, including static perimetry and microperimetry that were reported, and it's tabulated on the right. Beacon Therapeutics is currently conducting its phase 2-3 clinical trial. The results are obviously not available. Some of the earlier results were announced at the annual meeting in Chicago in 2024. Here it's, again, subretinal delivery using AAV2, and the response was a microperimetry change greater than 7 decibels in at least 5 loci. And at 24 months, they showed that 4 of 7 study eyes showed a response in the high-dose arm, and fortunately, no clinically significant safety events and treatment-emergent adverse effects were mild or moderate. Switching to the gene modifier approach, this has been something that's been pursued by a company called Ocugen for all forms of retinitis pigmentosa. So in their clinical trial, they're testing the hypothesis that all forms of RP may be potentially treatable with a subretinal delivery of the gene NR2E3. Currently, they have a phase 3 trial underway, which is associated with, trial underway in which they'll have half of the patients who have a Rho mutation and half the patients who have a gene agnostic mutation. And the idea here is that perhaps by modifying the expression of other genes, including Rho, CEP290, and so on, they might be able to promote a retinal homeostasis that can improve retinal function and retinal sensitivity. The primary outcome, much like the other trials, is a gain in lux levels on a luminance-dependent navigation assessment akin to a maze. And it was their earlier trial that was a phase 1-2 that demonstrated about 78% of eyes improved on that test. And among patients with Rho variants, 80% demonstrated preservation or improvement of vision. Optogenetics is a newer player in the field when it comes to a mechanism of action for visual restoration. There are several sponsors that are currently investigating the potential, including GenSight, BionicSight, and Nanoscope. Here the idea is you have a light-activated photoswitch that targets non-photoreceptor cell types in the retina. And again, it's a gene-agnostic approach that can potentially improve vision in patients regardless of the underlying genotype. Nanoscope reported last year the results of its phase 2 trial using a multi-wavelength cone opsin delivered intravitreally in patients with RP, and there were significant gains in vision at 52 weeks with a mean increase of 0.34 logmar compared to sham, and at 76 weeks, both gains in vision and the proportion of patients with more than 0.3 logmar were significantly elevated compared to sham. There are currently 4 different gene therapy approaches underway in phase 1-2 trials for ABCA4 retinopathy or Stargardt, and a handful of other phase 1-2 trials due to RS1, PDE6B, and MYO7A, although the results for many of these are obviously forthcoming. Among them, however, there was a remarkable result recently with the gene AIPL1. AIPL1 associated dystrophy is associated with very limited light perception at a very early age, and the idea that you could potentially treat patients within a very narrow window was supported by their findings that in 4 children that were treated, vision improved dramatically from 0.8 to 0.1 logmar from essentially light perception. Other outcome measures showed strong treatment effects, including improvements on VEP, functional vision, and retinal structure, although many of these assays were specifically designed or modified for measuring vision in very young individuals. So thank you for your attention, and just to conclude, there's a lot to look forward to in gene therapy for ophthalmic diseases.
Thank you, Dr. Hyde. Any questions from the crowd? Please.
How can we enroll our Indian patients into these trials, if it's possible?
Well, that is a great question. I think it is a matter of discussing with the sponsor and getting early involvement with sponsors and indicating that you have an infrastructure available to support clinical trials. The idea of conducting international or multinational clinical trials is one that I think many academic ophthalmology departments are pursuing in conjunction with industry. But I think it's one that I'm, this is the reason I'm here in India, to consider how we can better establish relationships to make these types of things happen.
Thank you.
Yeah.
Hi, nice talk, and particularly, although the results are mixed, but obviously it gets refined over a period of time. I was wondering about the last gene, the AIPL1, and with one of the patients with 3 different variations, like you had a missense, you had a duplication, as well as a frame shift. So what was the actual structure of the gene? Because when all of these are occurring together, what's the final end product which is being targeted? Because the missense is there, but prior to that there is a duplication and then a frame shift, which obviously would lead to a termination at some point of time of the protein. So what's the protein that is being targeted, and what was the outcome?
Yeah, so I think that's a great question. Obviously, I think you're speaking to the idea that there could be nonsense-mediated decay from early variants in the sequence. And to answer your question, frankly, I'm not sure. I can't speak to that very well.
Yeah, I just had a question about, you mentioned NR2E3, to sort of use that gene or express it to treat any other forms of, gene-associated disease, right? So is it, I presume then the action is that it generally stimulates the transcription of a number of photoreceptor genes. Is that how it works?
This is a very, I don't want to say controversial topic, but I think it is one that is very complex. NR2E3 and NRL are both transcription factors that modulate the expression of many downstream genes. That work by Nina Hayter in preclinical models used a number of different gene models, including CEP290 null, Rho null, and so forth, and showed that in response to delivery of NR2E3, there were improvements in ERGs, as well as on a whole host of transcription factors that are thought to be important for maintaining retinal function. It's a bit of a hand-waving explanation for what is probably a very difficult or very complex question involving a network of neural regulation.
Yeah. Any further questions? Okay, I think if there are no further questions, we will end here. Thank you very much.